All right, I am presenting on lumbar stenosis with sensory loss. So for our subjective data collection with the focus on the spine, we would do the following for review of systems. We would want to know about any changes in weight, if they've had fevers or chills. We want to know if they've had any balance changes, any numbness or tingling, headaches or vision changes, any shortness of breath or cough, any chest pain, if they've had issues with bowel or bladder incontinence, if they've had any joint pain, swelling, or joint redness, any known trauma to their joints, any decrease of range of motion in their joints, or any changes in strength. We would want to know about their past medical history, specifically if they have a history of rheumatoid arthritis, any history of cancer, history of osteoporosis. We'd want to know about any allergies or current medications. We'd want to know if they've had any previous spinal surgeries or any previous traumatic injuries. We'd want to know about their family history of musculoskeletal disease, and then if they've had any related musculoskeletal imaging, including x-rays, CTs, myelograms, or MRIs. For the history of present illness, we'd want to know when the pain started, if the symptoms were sudden or gradual, if coughing or sneezing makes it worse. We want to know exactly where the pain is located and if it radiates. How long does the pain last? Is it continuous or intermittent? How do they describe their pain, rating it on a scale of 1 to 10? We want to know if certain activities aggravate their pain or if certain positions or activities relieve their pain. We want to know what treatments they've tried at home and what treatments have helped. And then how much is their pain impacting their day-to-day life? So the clinical presentation with lumbar stenosis with sensory loss, the patient will have lower back pain. They'll have pain and weakness or numbness in the legs, calves, or buttocks. They may have cramping in the calves with walking. They may have pain radiating into one or both thighs and legs. They might have balance issues due to weakness in the foot. They may have sexual dysfunction, decreased or total loss of sensation in the feet. They might have difficulty getting up and out of a chair due to pain and weakness spreading from the spine to one or both legs. They might have symptoms, but the symptoms are typically bilateral but asymmetric. The entire leg is affected, not just where a single nerve root is located. Pain is exacerbated by standing and walking and relieved by forward flexion or rest. In severe cases, they might have issues with bowel or bladder incontinence. This is a red flag symptom that needs immediate treatment. And then they might also have saddle paresthesias, which is another red flag symptom.
Okay, to begin our musculoskeletal exam that's focused on the spine, knowing that the patient is presenting with lower back pain and some numbness and tingling of either one or both legs, we would begin by inspecting the spine. So we're looking for any abnormal curvature of the cervical spine or of the lumbar spine. We're looking for any kyphosis or lordosis here, and then any scoliosis. A sign of scoliosis is if the patient has one shoulder blade that's higher than the other. Another position that's helpful for inspecting scoliosis, to have the patient flex forward and looking for any abnormal curvature or the S shape of the spine that could mean scoliosis. While the patient is flexed forward, it's important to note if they do have relief of their lumbar spine pain, as this can indicate lumbar stenosis. We'll then have the patient stand erect. We're just observing overall posture here, any deformities or asymmetries, and then we can have the patient extend backwards. This often causes worsening lumbar spine pain if the patient does have lumbar stenosis. From here, we can have the patient do range of motion with their neck looking to the right and then to the left, and then making circles in each direction. And then we will have the patient do lateral movements here to the right and the left, noting any pain or limited range of motion. And then last, we'll test rotation, have the patient turn each direction, again, noticing limited range of motion or any discomfort with that. While the patient is standing, we will observe the patient walking. We'll ask them to walk on their tiptoes to begin with. And if one foot is dragging or not up, that can indicate L5 involvement. Then we'll have the patient walk on their heels. And any asymmetry here, or if one foot is dragging, that can indicate S1 involvement. Following that, we would have the patient lie supine and begin our provocative exams. The first test we have here is the raising leg test. So we'll raise the leg from 30 to 60 degrees and ask the patient if they experience pain at any time. A positive test would be if the patient does experience pain here. This indicates nerve impingement. And then we could have the patient dorsiflex their foot to validate this pain. We can do the same thing on the contralateral leg, and a positive test here is if the patient feels pain on the affected side. From here, we could do the Faber test. We'd have the patient cross their affected leg over the opposite knee. We are assessing for range of motion with this crossover knee. So the knee should be able to pretty much hit the exam table. If it remains higher than the extended straight leg, that can indicate some SI joint involvement here. From here, we'll have the patient roll over and get in the prone position. And we'll do the femoral stretch test. A positive test here is if the patient feels pain in the anterior side of their thigh. This puts additional stress under the femoral nerve, which is why they would feel pain there. The last test we will do is the tripod exam. So this exam involves raising the affected leg. A negative sign is if the patient doesn't feel pain and remains upright. A positive sign is if the patient experiences pain and extends both arms behind them. If any of these tests were positive, we would then follow up with a more detailed neuro exam, including motor, sensory, and reflexes.
Risk-specific considerations are if the patient has a history of arthritis, if they're older than 60 years of age, they are female, if they have a history of scoliosis or achondroplasia, any tumors in the spine, if they've had previous spinal trauma, or if they are obese. Here are a list of my differentials and attached are my references.